everybody, and welcome to what I hope is going to be I know is going to be a very exciting presentation. We are going to be talking about the Millennial generation, which we'll have to have a few definitions of that, managing the boom of innovative therapy to transform myeloma care and enhance patient outcomes. Really excited to have you here today, and looking forward to a really nice presentation as well as active discussion. I want to welcome everyone here today, and also people that are joining us virtually. Tonight, for panelists, we have myself, Nina Shah from the University of California, San Francisco. We have Dr. Shahji Kumar from the Mayo Clinic, and Dr. Sagar Lonial from Emory. We really want to say thank you to PeerView and the Health Tree Foundation, especially for multiple myeloma, Health Tree for multiple myeloma, for providing this session, and Bristol Myers Squibb, as well as GlaxoSmithKline, Janssen, and Karyopharm Therapeutics for providing the educational grants for this symposium. So if you haven't already, please complete the pre-event survey, and then just a reminder to look out for additional follow-up polling during the presentation, and then you can submit your questions and we'll answer them during the Q&A. We'll probably do that at the end of all of the slide presentation. Another note to just visit us at peerview.com/2022 myeloma. You can see these slides and practice aids. Download them after the event. That'll help you in case you want to see anything else that you might have missed during the presentation. So want to talk a little bit about making sense of innovation in myeloma care. As I printed out, as I already talked about, I'm Nina Shah from Department of Medicine at UCSF, University of California, San Francisco, and I'm excited to talk about a really I would say innovative, exciting field in hematologic malignancies, which is multiple myeloma. We've had so much innovation in the past 2 years, and even now at this meeting, we're seeing more data. So the shape of modern myeloma therapy is continuing to change, and I would say it's almost changing daily. We're really trying to build on past successes, and when we talk about a millennial generation of innovative therapeutics, we're talking about a generation of therapeutics that's really rapidly expanded our options. So we know that we have PIs and IMiDs, but in addition to the proteasome inhibitors and the immunomodulatory platforms, we now have additional items, including CD38 antibodies. And I would say they are now part of standard upfront therapy. We're going to talk about the data that supports that. So there's both triplets and quads, depending on which patients you're talking about. Now, in relapsed refractory multiple myeloma, we know that there are potent antibody triplets. And then there are other drugs with novel mechanism of action, for example, inhibiting XPO1. And then, of course, in relapsed refractory multiple myeloma, we have Bcma directed options and even other targets as well, looking at antibody drug conjugates, chimeric antigen receptor T cells, also known as Carte cells, and soon bispecific T cell engagers. So just a lot of therapy that we wouldn't have even been able to talk about 4 or 5 years ago. Really, there's been an explosion, and hopefully we can put that all into context and understand how we may use these novel therapeutics and these new platforms in this millennial generation. So the only thing that we have to think about on the other side, though, is that despite progress with these newer therapeutics, challenges remain in delivering effective treatment to myeloma patients. So we have some issues, right? People are on therapy for a long time. Maybe they don't want to be. Therapeutic attrition rates suggest that many patients are not exposed to the full benefits of the modern therapeutic arsenal. And that means that all patients are not necessarily getting all therapeutics. And if you look at the data, the assessment of patients with myeloma, and looking, for example, at this cohort of 22,000 patients not eligible for transplant, it looks like only a little over half of them, so 57%, receive only one line of therapy. And if you think about the fact that we talk about people in line 6, 7, and 8, these people are not getting enough therapy, they're not getting enough opportunity for therapy, and we really want to change that as we go on in trying to educate our patients, our providers, ourselves, and the entire myeloma team to help patients get access to these new, very effective care, or very effective options and therapeutic options. Now, also in this study, you can see that there are 2,700 patients receiving transplant. Only 21% received only one line of therapy. So, for example, in this case, the transplant was the last treatment, and they didn't receive subsequent lines of therapy. And if you think about even this data might be a little bit outdated, these people probably never had things like Daratumumab, certainly didn't have any of the novel of immunotherapies that we're going to be talking about. So we really want to make sure that we make this something of the past and not of the future, that we make these therapies available, that patients have logistical pathways to get there, and that we provide education so that patients know about it and that providers know about it. So if you have multiple refractory disease and multiple myeloma, this is a clinical challenge. So here you can see that this is the Mammoth data. This is a cohort of patients that have been exposed to multiple therapies, but most importantly, anti-CD38 antibodies. And we use this data a lot to show how patients are doing. You can see from the curves that these patients with triple-class refractory multiple myeloma experienced very poor survival and substantial hospitalizations and a clinically meaningful decline in quality of life. And that is important because, as we already talked about, myeloma is an incurable disease, and quality of life really plays into it, not only because of disease burden, but because of the number of therapies and the length of therapies that people have to have. In addition, we saw that over a third of these triple-class refractory patients did not receive any new line of therapy, meaning that, in a sense, they didn't get anything else. I don't want to say giving up, but there wasn't any other option for them. And those patients uniformly do very bad because they don't have any therapy that's addressing their myeloma. And for people who did receive an additional line of therapy, treatment with IMiDs, PIs, or anti-CD38 antibody was common, and that means that they had repeated things given to them or repeated classes of drugs, which means that there is an unmet need for new therapeutic modalities and new therapeutic options. And you can see for patients on the right-hand side that are not triple refractory versus those that are triple and quad refractory and penta refractory, at each line of refractoriness, the ability to survive and the time that these patients survive is certainly less, and it's clearly an unmet need for patients with relapsed refractory multiple myeloma. So today we're going to have a seminar and tumor board session. It's going to be case-based explorations of primary therapy, maintenance choices, and options for relapsed refractory multiple myeloma that's going to include antibodies, novel mechanism of action drugs, as well as BCMA-directed therapy. And we hope that you'll find this both educational and sort of a pathway for how we might be approaching the myeloma patient now in this myelonial generation. We want to thank our partners, our Health3 Foundation, formerly known as Myeloma Crowd. I'm really excited that they're here today. They really support a patient-centric community that's enabled with data tools to improve patient outcomes and deliver faster cures. I really encourage you to go to their website. It has been a real wonderful resource for us as providers even to also have our patients engaged on this. So I want to say thank you to them for being our partners today. So first steps of the myelonial generation, exploring potent upfront regimens. So we're going to have a couple of different sections today, and we're going to each split them up and talk about them, and we're really hoping that we can generate some good questions for discussion at the end of the session. And we will have some case-based approaches and discussion between the three of us so you get a better idea. Sometimes one answer isn't the correct answer. Sometimes there's more than one correct answer, and sometimes it depends on your experience. So we're going to talk about a case, choosing options for an older transplant ineligible patient. So this is Robert, 74-year-old patient with standard risk ISS, that's International Staging System 1 myeloma. So he presented with symptomatic myeloma with standard risk disease, and at the time of diagnosis had 50% plasma cells without high-risk cytogenetics or FISH. His comorbidities include a history of CHF that's well controlled, but he's determined to be transplant ineligible after initial assessment, likely related to the CHF. So now we want to talk about what the optimal upfront platform of this will be, and let's review the evidence. And for that, I'm going to turn it over to Dr. Kumar for the subsequent discussion.
Thank you so much, Nina, for that. So we will, we'll just review about start with reviewing some of the basic principles, right? And also look at it from the context of how the field has evolved up until now. And obviously, we have seen the data with the bortezomib, lenalidomide, dexamethasone combination, and the SWOG trial clearly showed that it improves progression-free survival and overall survival for those newly diagnosed patients. And subsequently, there have been smaller studies looking at more or less intense versions of VRD, like the VRD Lite, which again shows a quite comparable PFS of about 3 years in the patients who are frail, who are older. And obviously, this has become the backbone for us to try and improve that initial therapy of multiple myeloma. So you will hear from Dr. Lonial later on how we can add the monoclonal antibodies to the VRD backbone. So I think the key thing for the patients with newly diagnosed myeloma who are ineligible for stem cell transplant is that where do we go from there? Obviously, VRD is good. VRD Lite is very tolerable for this patient population. And I think the regimen that we end up using in these newly diagnosed transplant ineligible patients obviously has to take into account a variety of different factors, what is unique to this patient population. So they are obviously older, they are more frail, they have less social support, they often have other comorbidities, and it's and they are likely to see a lot more toxicity to the same drugs or drug combinations compared to the younger patient population. So when you look at the different regimens, in addition to the bortezomib, lenalidomide, dexamethasone, now we also have the combination of daratumumab with lenalidomide, dexamethasone, or the DRD regimen, as was studied in the Maya trial, which we'll go into in a little bit more detail in the next few slides. And then there are other regimens that have been studied in this patient population in phase 2 studies, as well as in some of phase 3 trials. Like carfilzomib lendex as well as ixazomib lendex has been studied in this patient population in phase 3 and 2 settings, and also the daratumumab in combination with alkylating agents, whether it be melphalan or cyclophosphamide, have also been studied. So I think the data that has really kind of taken us to the next level in this particular patient population is the data from the Maya study, which looked at adding daratumumab to lenalidomide and dexamethasone. And as you can see here, the addition of daratumumab significantly improved the progression-free survival. But I think more importantly, it also has led to an improved overall survival. And this regimen was very well tolerated in this patient population. And one of the things that always comes up is, how frail are these patient population, and does it make a difference? And when you look at the subgroup analysis, it's very clear whether you're talking about this older patient population who are frail or not frail. The impact or the improvement that we saw with the addition of daratumumab appear to be quite comparable when you add that to the lendex. Now, obviously, one of the reasons why we, or one of the advantages that we have seen with these newer regimens, particularly the ones that have added the CD38 targeting monoclonal antibodies, have been the depth of response. We are certainly getting a higher rates of complete response and obviously more minimum MRD negative states in these patients in these recent trials. And the same thing was seen with the Maya study as well. A higher proportion of patients were able to get to be MRD negative, and they were more likely to stay MRD negative if they were on the daratumumab containing arm. And this obviously translated to a better progression-free survival for this patient population, particularly those patients who had their MRD stay or sustained. So clearly, in this patient population, we have to take into account a variety of different factors when you decide on selecting the optimal regimen. So clearly now we have the VRD or the VRD light maybe more appropriately in this patient population, and we also have the daratumumab lendex from the Maya study. Now, does that mean we would not use doublets at all? I think there's still some places where you might start off with a doublet at least. And if you have a patient who is really old, who is really frail, and you are really concerned whether this patient can actually tolerate 3 drugs, I think many of us in the practice tend to start off with lenalidomide and dexamethasone, obviously a lower dose of dexamethasone, give a cycle, and then see how their tolerance is, and then start adding the third drug to the combination. Obviously, it also depends on how fast you need a response, right? Obviously, somebody comes in with renal insufficiency, we may not have time to these kind of scaled up approaches, and then we might start these patients in more on the triplet right away. You also want to take into account what are the underlying comorbidities, right? So we have 2 regimens, and sometimes we have to decide between the 2, and we don't have data comparing these 2 triplet regimens in a single phase 3. Obviously, we have one phase 3 that shows the PFS for the VRD is about 36 months, and we have the Maya trial, with the PFS that's over 50 months in that patient population. But there are certain patients, for example, somebody with diabetes and diabetic neuropathy, you certainly don't want to use a bortezomib-based regimen. Somebody with high risk factors, this particular patient had standard risk, which is much more easier choice. But if somebody had high-risk cytogenetics, then that may be a patient where you might want to think about using a VRD-based regimen to start off with. And if they really, do very well, you could even consider adding a 4th drug to that, as we may do in the younger patient population. So clearly now the question then comes up is, what do we do after we start these patients on the on the initial treatment, and how long do we continue the therapy? And maybe I'll stop there and maybe hand it back to you, Nina, and see what the specific points we need to discuss as well.
Yeah, actually, this is great, and I'm actually going to go back a slide just to talk about how are we determining what to do for our standard risk. So let's start with standard risk. Our standard risk transplant ineligible patients, and I think the first thing is, okay, determining transplant eligibility. We'll put that aside for the discussion because that's a whole different discussion between different providers and patients. But assuming the patient is considered to be transplant ineligible for whatever reason, what have you started to use, you personally, in the setting of being able to use any of these regimens? What is your choice right now?
Yeah, I've kind of defaulted to the DRD regimen for these transplant ineligible patients as the initial therapy, except in certain situations, obviously the high-risk patients in particular.
Right.
But in the standard risk patients, clearly the DRD is the default regimen.
And Sagar, what about you?
Yeah, I think I would approach it the same way, DRD for standard risk and consider VRD for the high risk. You know, Shah, you bring up an important point, though, which is in some patients we may think about DARA RVD in the older, frailer patient population. And I guess my point would be if you think you can give them a quad, maybe they're not frail, right? Because a quad is tough, certainly, for a frail older patient.
But certainly some of those patients who look frail, you start them on something, 2 months later they look much better, and that may be a place to consider that.
It's like evolving frailty, and that is a really good point because it's important that patients, if they're going to be determined to be transplant ineligible, that someone takes a look at them at the beginning and maybe 2 cycles in, right? So because people may have had myeloma-related morbidity that's getting better. I want to talk about this issue about the doublet, and you know we are always taught triplets, quads, that's the way to go. But you make a very good point that there are some people that are best served by doublet. And now that has changed. We have sort of different, you could give them VD, RD, DD. What do you do if it's doublet? What do you like to do in this particular patient population?
Yeah, I prefer to use the RD, but obviously those frail patients with significant renal dysfunction, that may not be the ideal thing to do. And those are the patients where I would start using, you know, maybe bortezomib dex to start with and see how you do. And, you know, certainly want to consider maybe even in those patients, a daratumumab bortezomib dex combination in some of those patients coming in with renal insufficiency.
Right.
Again, a triplet, but still not the 2 we talked about.
Not the ones on the multiple choice test. What about you, Sagar? What about your thoughts on doublet?
Yeah, you know, I will say my approach has softened probably in the last few years when I've probably beat up some older patients by hitting too hard early on. In an older, frailer patient, less for longer may be better than more for shorter. So thinking about that balance, I think, is really important. I will say, you know, the renal insufficiency case that Shahji brought up, you know, one of the quickest ways to reverse renal dysfunction is actually DARA. And when you think about, sort of for me, the index older, frailer patient that got DRD was an 82-year-old who sailed through DRD, had 3 daughters that were always with her in the clinic for the first year, now drives herself to clinic and is doing fine. So I think DARA is not one of those that adds in terms of intensity of therapy.
Yeah. So I think, in fact, in our own practice, and I don't know what you do as well, is the renal patients predominantly have been using DVD, and once the renal functions improve, you can add the LEN into that mix as well.
That's right.
Yeah. We're actually going to have you repeat the question, and actually we'll do one question now, and then we'll save them for the end, but yeah.
I mean, my question is, like, sometimes patients can't just handle Revlimid, either severe skin reaction or cytopenia. So, like, that transplant ineligible, standard risk, you start on DRD, then you drop so now you're doing doublet. Should you continue doublet, or should you kind of bring in DVD at that point?
I mean, personally, I would prefer to add the bortezomib, and knowing that we're going to give it for 4 to 6 cycles, and then obviously continue with the DARA after that.
Yeah, I agree.
You know, I'll say at least one of the things that we often do is the skin rash comes up early on, and then everybody's afraid to give it again. If you started at 15 or 25, I have a lot of people that had rashes that do fine with 5. And 5 may be a great dose. I mean, if you look at the original phase 1 dose escalation of LEN, the first patient at 5 actually had a VGPR, I think, if I remember correctly. So the lower doses can be fine, and I even go to 2.5 in the older patients just to get a little bit of that IMiD activity in there because they may need less.
Yeah, and again, most of the times you stop the Revlimid, the lenalidomide, and you come back to it at lower dose. Majority of the patients don't get a rash after that. So this is assuming that this patient just couldn't tolerate at all.
Right.
So,
Right.
And actually, this is a really good segue into the next slide, which I think is, we have to talk about how we really manage these patients, right? The Maya trial did have people getting DRD indefinitely, essentially, right, because PFS was the primary endpoint. But what do we think about maintenance lenalidomide in the setting of this transplant ineligible patients? And if you're using RVD light, which some people still use, and it's not a bad option at all, do you go to len maintenance? Or if you're using DRD, do you do a maintenance dose? Or what is the real world way to approach extended therapy for these patients who are not going to go to transplant?
That's a good point, and I think the Maya study just by design has locked us into using the Dara-Len maintenance. But if you look at the first trial, which was the RD, obviously that was Len continued. Same thing with the VRD regimen, it was a Len maintenance. So at some point, if I would drop the Dara first and then continue the Len if I were to continue on just one drug, and somebody who started on DRD and they just cannot take both the drugs continuously, my first drug to drop would be Dara in that setting, just because we have so much more data with the longer-term Len. But I think one thing I do want to point out in this setting is the fact that we should consider dropping the dexamethasone after the first 8 to 9 cycles, again, based on the Italian data as well.
Yeah.
Sagar, your thoughts?
Yeah, no, I agree. I think the use of Dara alone in the maintenance phase, to me, is a softer data. It's a data-free zone. With Len, we clearly have data. But, if you're choosing DRD because of 60-month PFS, you kind of need to continue both. And I agree, stopping the dex makes perfect sense, but I think you want to give both if you want to be faithful to the trial.
Yeah, I think what I'm seeing, and I don't know if you guys do the same, is that you get a few months. I mean, a lot of these patients, their disease burden drops nicely, very quickly. And then after, a couple cycles, maybe 8 cycles, you can really decrease that Len dose. And you're still giving them the synergistic effects of having both drugs on board. And I agree, dexamethasone makes less sense, especially at the higher doses. I mean, I honestly sometimes don't even give more than 20 to start for some of these patients because they are more frail. So I think these are really important points. Just a real brief question about if you decide to do RVD light, how many cycles do you give before you switch to Len maintenance alone?
I try to give 12 cycles if I can, if they can tolerate it, because it's once weekly bodies and if they're able to go on longer. But I think
I'm between 8 and 12, depending upon what you can get away with. But when I do modified RVD, I do it on the 28-day cycle, not the 35-day cycle, because I can't keep that straight in my head.
No other reason. Great. All right, well, this is a really good discussion. It leads us really nicely into the next segment, and we're going to have some questions. We're going to take a moment to answer a follow-up polling question on primary therapy for patients who are unwilling to pursue or are considered transplant ineligible. Okay, sorry. So is the question on the iPad? I'm sorry.
Yeah, it doesn't show up on this, but it's on the iPad.
Okay. Great.
I'll answer for you.
You'll answer for me. Awesome. Oh, I didn't see that. Okay. All right, great. So we are going to go on to the next section, and we actually have another case, a little bit different here, also newly diagnosed. This is the Tumor Board 2 question, choosing options for a transplant-eligible patient. So in this case, Margaret is a fit 68-year-old patient with revised ISS2 multiple myeloma. She doesn't have any major comorbidities. She has normal renal function, and she's determined to be transplant-eligible after initial assessment. So given the transplant eligibility, what's an appropriate induction regimen, and is there a role for a quadruplet? So for this, I'm going to hand it over to Dr. Lonial.
Thank you. And this is such a rapidly evolving area that I think it's worth spending a few moments sort of talking through where is the level of evidence, and I'm sure Nina will quiz us on how we approach it in our practices as well. But when you look at the highest level of evidence as certified or endorsed by the NCCN, RVD continues to be the Category 1 recommendation of choice. There are others that you can see that are there, including KRD, Dara-RVD, and even IRD. But I think if you look at what does, in fact, have the highest level of evidence, it is RVD based on randomized phase 3 data. Now, I want to set the standard, if you will, for where we are in 2022. And this is data that we published 2 years ago from our group, which is 1,000 consecutively treated patients who all got RVD induction, had a transplant, and then got risk-adapted maintenance. And by risk-adapted maintenance, what I mean is Len for standard risk patients, continuous therapy. And then for the high-risk patients, they got RVD consolidation and maintenance for 3 years. And if they were still in remission at the end of 3 years, they just went to single-agent Len after that. And what I think you'll notice here is that the expected PFS for all patients in aggregate was 65 months. So that's 5.5 years was the expected PFS. The median overall survival was over 120 months. That's greater than 10 years. That's the longest PFS and OS reported in a large series in the modern era using great drugs like we have. And for those of you who are paying attention to the plenary session tomorrow, you will see the randomized trial of RVD transplant versus RVD without transplant. And what I think you'll see is data that certainly continues, in my mind, to really be supportive of some of the concepts that I'm showing you here. More importantly, if you look at the standard risk patients in orange on the bottom curve, the PFS is 78 months. So if you're a standard risk patient, you get a transplant and single agent len maintenance, that's almost 7 years of progression-free survival from the time of diagnosis. And so when people start to talk about you don't have to do a transplant, you can wait, what are you really giving up when the disease is at its most sensitive? Because we know that the PFS, at least from the IFM study, is actually shorter if you delay the transplant. So that first remission is when the disease is most sensitive. And at least in my mind, the primary endpoint in newly diagnosed myeloma should be prolonging PFS for as long as you can to give patients the best opportunity for long-term outcomes. Now the question is, can you do better? And this is the European first attempt to try and do better. And this was the addition of DARA to VTD in the blue on the top versus VTD in the orange on the bottom. And notice that everybody got a transplant, everybody gets consolidation, and everybody in the blue curve gets maintenance. And this is where it gets tricky. Because when you start to look at long-term or even short-term outcomes like PFS, I'm going to show you where on the curve things start to separate. And I'll let you guess what happens at that time point. But I think the fact that there's a randomization between DARA alone versus observation is a major weakness in this trial. And so when I look at this trial, what I'm really looking for is depth of response before and immediately after transplant, because that's where I think DARA really has its greatest impact. I'm not sure I can use this to really measure PFS. So one of the outcomes that was looked at in this, which is actually a very interesting endpoint to look at, is the idea that whether you got DARA up front or you got DARA in maintenance, it didn't matter. The PFS was the same. And for those of you who remember the old story of rituximab, do you give it in induction? Do you give it in maintenance in lymphoma? It's the same story. You just need to get rituximab at some point. And in my mind, if you're going to give it early so that you can have a less intensive maintenance therapy with just len alone, as opposed to giving chronic administration of DARA in the maintenance phase where you may change infection risks and other things along those lines. And just for internal consistency, if you look at that orange curve, what you'll see is that the VTD without DARA and no maintenance had a median PFS that's almost identical to all the old trials of transplant without maintenance therapy. So it's not like the orange curve did worse. It did what we used to see when we didn't give maintenance. We now know that you have to give maintenance in order to really prolong that PFS early on. So in terms of what's more relevant for us in the U.S., the standard of care is not VTD, it's RVD. And the randomized phase 2 Griffin study probably gives us a better insight in terms of what the benefit of DARA could be. And if you remember from Griffin, it was almost like Cassiopeia, RVD with DARA, transplant, RVD with DARA, and then len plus DARA maintenance. And in the control arm, it was RVD, transplant, RVD consolidation, and len maintenance. So it's a much more apples-to-apples comparison in terms of what DARA really brings to the table throughout the treatment cohort. And what I think you'll see here quite nicely is that at every point in the process, the depth of response is clearly higher with the addition of DARA than it is in the orange curves without DARA. And that's important because this, to me, speaks to why you may want to think about using DARA as part of your induction therapy. You deepen the response early on. That then translates into better post-transplant PFS, translates into better post-transplant response rates as well, and likely higher rates of MRD negativity. And just to speak to that, again, what you'll see here is that MRD negativity clearly is better. If you look on the left, sustained MRD of greater than 6 months is almost threefold higher in the group that got DARA, and sustained MRD negativity of greater than 12 months is also threefold higher in the group that got DARA compared to the group that did not. Now, What you'll notice on the right side of this figure is that at 3 years, the progression-free survival curves are, in fact, beginning to separate. They didn't separate for the first couple of years, which you could say, well, you know, this is really good therapy. The control arm is getting really good therapy. And in fact, if you track the orange curve with the RVD 1000 series that I showed you in the beginning, it's almost completely superimposable. So that RVD without DARA arm is performing the way we would expect it. And it took 3 years to really begin for those PFS curves to separate. And that, to me, really demonstrates, again, the value of adding DARA early on in the approach. Now, you can look at who these patients were in terms of subgroup analysis on the whisker plot. Pretty much everything is to the left of the line here, favoring DARA. They're not all statistically significant. This was a randomized phase 2 study, so it's a little bit underpowered to show some of these subsets, but certainly the Perseus trial from the EMN is going to answer these questions in a much larger patient population and will, in fact, be powered to address some of these questions as well. Now, we've talked a lot about DARA as the antibody to bring in. What about isatuximab? And this is the German study group where they looked at ISA plus VRD versus VRD, followed by transplant, followed by second randomization to ISA-len or lenalidomide alone. And what you'll notice, the primary endpoint is on the left side of this graph here, and you'll see the primary endpoint was MRD negativity at the end of induction, 50% versus 35%, favoring the use of isatuximab. And you may remember from the previous slides that that 50% is higher than we saw in Griffin at the end of induction. And the reason is, in the German study group, they gave 6 cycles of induction, not 4, which is what we typically do in U.S. trials. And so the reason you're seeing that deeper at 10 to the minus 5 response rate is they got 2 additional cycles of therapy over what we would traditionally give as part of induction therapy. So again, in this 68-year-old fit patient with RISS2 myeloma, no major comorbidities and renal dysfunction, transplant eligible after initial induction, is a CD38 quad an option given her baseline assessments? And I'll pass it back to you, Nina.
Great. I think this is a really good place for us to have a discussion about the things that have really been changing rapidly in myeloma. Things even a year ago, I think we had different data than we have now. And I want to get an idea about how to apply this group regimen in your practice. I know we said we were going to talk about what we do normally, and I think there are some differing opinions. So I'll start with you, Sagar. First of all, are you giving quad therapy? That's the first question.
Yeah, we're using DARA RVD as part of our induction therapy for standard risk patients. Yeah.
Okay. And what about you, Shaji?
We're doing exactly the opposite, and we always do that part of it. So we use the quad primarily for the high-risk patients, where we are still using the VRD for our standard risk patients pre-transplant.
Yeah, and I've gone back and forth too. Actually, after seeing the PFS data from Griffin that was updated at ASH, I do feel that we are getting there better with quad, and so we've switched to quad therapy as induction in general. And the interesting thing about the data that was just presented today is the MRD negativity sustainability, which you've highlighted that at both 6 and 12 months, it's more possible to be having sustained MRD negativity with the quad. But even if you get to MRD negativity, the patients who got DARA and got MRD negativity seem to be doing a little better than the patients who got MRD negativity without DARA. So, and that's not, we don't know yet. I mean, we're really slicing and dicing numbers, but so that's an interesting thing about what DARA may be doing in the induction settings. Okay, so if you do give, if you were going to give DARA RVD up front, what would you do with the maintenance DARA? What would you do?
So at least in our practice, because we are using for the high-risk patients, the maintenance is always bortezomib and len maintenance post-transplant for those patients.
Right.
So it's a quadruplet for 4 to 6 cycles, transplant, VR maintenance afterwards.
Okay. And Sagar, what about you?
Yeah, so we are using, so if you go back to RVD 1000 again, the median PFS for standard risk is 80 months. That's pretty good. And do you really know that adding DARA is going to make that better? And so based on the fact that we don't know, we only give the DARA for the first 4 cycles of induction and then go to single-agent len for the standard risk. For the high risk, we do KRD up front and then do KRD in the maintenance consolidation. But I think you've raised a really interesting question that I'm sure the three of us could argue about for hours here, which is, are all MRDs the same? If you said, and I interpret the data the same way, that DARA MRD negativity has a longer PFS than non-DARA, from the IFM trial, the French version, transplant MRD negativity lasts longer, has a better PFS than non-transplant MRD negativity. Those, to me, are all important variables and tell me that MRD is a dynamic endpoint that needs to be added to as opposed to a standalone.
But Sagar, also the Griffin, Dara MRD, those patients are supported by Dara and Len afterwards for a longer period of time compared to the RVD arm where it's only Len maintenance.
Right.
Yeah.
And
sorry, finish.
no, I was just saying, one of the reasons why we haven't quite adopted, I mean, the data is so good with Griffin, but we haven't adopted for the standard risk patients is if you look at the Griffin trial, 32% of the patients in the RVD arm did not get Len maintenance compared to almost 18% of patients in the quadruplet arm. That also feeds into that difference in the PFS that we have seen so far. So it'll be, I'm sure we'll all switch to quadruplets, but we're just waiting for a little bit more data.
Yeah.
Yeah.
There was more dropout in the RVD arm as well. So actually, because I'm a mentee of Sagar, I have thought about what we do as upfront, and he's really drilled into me that the best you do is up front is really important. These people are living for a very long time. They're going to their kids' weddings. They're doing a lot of important things, and you want to make that go as long as possible. So that's why I'm giving Daryl and maintenance for the Griffin trial, because I feel like the PFS curves are dividing out even beyond the induction part of it. I think the GMMG data is actually very helpful to know that we are making a difference in induction, so that I'm very happy to see that with anti-CD38 antibody. But I think that there are some benefit to having this doublet maintenance. We will see, and there are side effects of doing that, and there are financial side effects and also just some downstream side effects, but we'll see what happens. So I'm just kind of doing it like the trial, and we'll see what happens.
I do think the value proposition of doublet in standard risk is that you don't give it forever,
Possibly.
which is currently the way that we approach Len maintenance.
Yes.
We treat until progression or toxicity. If Len, Dara, or KR is going to be used in standard risk, but it means you only need to go for 2 years.
Right.
That's a win, right?
Well, I will say that, in the Griffin trial that they, as you know, stopped the Dara-Len at the 2 years of maintenance, but many of my patients just continued on Len because, of course, I am a believer in Len maintenance. So I think you're right, we may get information about that. It'll be just that they got that extra 2 years. So great discussion. So we talked a little bit about this. If you do Dara-RVD with the maintenance approach, we talked a little bit about this. So Sagar was saying he just switches to R maintenance, and Shaji was saying because they use this in high-risk patients, he tends to use PI-based maintenance in those patients, and I said I do DR maintenance. So you got 3 different answers from the 3 different people, so that's one of the great things about these types of symposia. All right, so we're going to have another question. This should be on your iPad. Take a moment to answer this follow-up polling question on induction therapy for transplant-eligible patients for myeloma. Okay, great. Okay, we are going to move on to our next category, but before we go there, we want to talk about practical points on CD38 antibody safety. I think in general, antibody platforms have been extremely well tolerated. We just had this discussion about how patients are patients are frail, but they're still tolerating Daratumumab very well. And in fact, there is a good amount of data and different studies, small phase 2 studies have looked at patients getting Dara in combination, frail patients actually defined as frail with frailty scores, and they're tolerating it very well. So I agree with this. We also know, just as a side note, that Daratumumab is well tolerated in our amyloid patients, and those patients tend to be very sick. So we feel comfortable giving this therapy. And antibodies are associated, unfortunately, with hypogammaglobulinemia, so we do consider prophylactic IVIG. That is a different thing for a different provider, and it really is a discussion with your patient. In general, if patients are only on Dara-based maintenance therapy or Dara-based therapy because of induction or second line, then I'll really think about if they have infections or not and make that a reason to get IVIG. But you do have to treat the infections very aggressively. As you've probably all seen in the Griffin data, there were slightly more cytopenias with the addition of Daratumumab. You have to think about that. Use of subQ Daratumumab has essentially eliminated severe infusion-associated reactions. It's really been a nice change in our practice, and it definitely decreases the chair times. We talked about the cytopenias in combination with both. We talked about Dara-VRD, but also Dara-pomalidomide. Those are things that you have to think about. out, I do use a lot of growth factor support. And there should be some caution because there are patients who are not mounting COVID vaccine responses that are on Daratumumab. We've talked a little bit about what you do with those patients. Do you give them Evusheld? Some patients get multiple vaccines and still don't mount responses. And we don't know, and the pandemic is going to change also in quality. So we don't know how those patients are going to be handled or how this is going to affect the patients. But if patients are compromised, you can make a case for them to get Evusheld if they're not making antibody response to vaccines. Again, want to...
if you mind if I just make a quick
Yes,
addition?
please.
So the COVID question is really important because many groups, including ours, and I think Shahji's has and others, have suggested that if you're on an anti-CD38, you're not going to mount a vaccine. And many people are using antibodies as a surrogate for whether or not you've responded. But what Madhav and our group has shown is that many patients with myeloma actually mount non-neutralizing antibodies. Mm-hmm. So those antibodies are actually a false positive. They're not real. They don't protect you. And so I would actually argue that anybody getting into DARA should be getting Evusheld as protection unless you know they're getting something else that has neutralizing antibodies in it.
Yeah, and I think the flip side of that, I agree with you, but you can also think there might be T-cell responses that we're not seeing that maybe the Daratumumab isn't affecting. We don't know, but I think it's better to err on the side of caution. I agree with you that these patients should probably get Evusheld. Do you have any thoughts on this?
No, I completely agree. I think we just can't assume that even if you see something, it's going to be really protective.
Right.
Yeah.
Okay, perfect. So I want to talk a little bit about the Health3 Foundation. As I mentioned, it's a huge resource for our patients, and it's really focused on patient empowerment. There's a lot of educational aspects of this, including Health3 News. There's a Health3 community events that patients can attend. There's podcasts and roundtables. We've participated in one just recently, and really interesting ways that patients can connect with each other, as well as looking at trying to find a specialist and maybe one near them, trying to empower patients to understand that they may be eligible for clinical trials and therefore they should maybe reach out to somebody who has access to these clinical trials. There are myeloma coaches that are sometimes patients that have had experiences. They're able to coach other patients through that. There's a learning module part of it, the University of Myeloma, which allows patients to become better educated for their own disease, and Clinical Trial Finder as well, which I think is really good for patients who may not have those resources in the community practice or whatever practice that they're in. There's also now this Health3 Moves app to try to encourage physical activity for patients who are suffering with myeloma and seeing what they can do to keep themselves as healthy as possible for this marathon. Also journaling and social media resources that patients can plug into. So it's really a large platform that has multiple ways for patients to be educated, to be empowered through education, and also to engage their care team as well as, which is just not only their providers, but also their loved ones as well. So if you have a chance, check it out. A lot of exciting things going on there, and a lot of ways that data can be put back into the system so that we can all learn from patients' experiences. So now we want to move on to the next part of myeloma, applying the therapeutic boom in relapsed refractory multiple myeloma, which is antibodies, targeted strategies, and Carte therapy. Really exciting. I mean, just this has been an explosive field. I want to talk about the next case, the third case, choosing sequential therapy for a patient who's relapsing on lenalidomide maintenance therapy. And this is, I think, really a lot of the patients that we see in our clinic. So this is Bertrand, diagnosed as 67 years old, revised IS stage 1 myeloma. He had a pretty good performance status, got RVD, then transplant, subsequently received R maintenance, and then progression was noted after 3 years. Had a little bit of renal insufficiency, but pretty well tolerated, and a little bit of neuropathy. So first of all, how can we characterize this patient's relapse, and what are the appropriate treatment options? And then to go into that, we're going to go into the principles of therapy with relapsed refractory myeloma. I'll turn it back over to Shahji.
Thanks, Nina. So I think, one of the questions you had there, is how do you characterize this patient's relapse, right? I think that's one of the things we always need to think about when you talk about disease relapse. We know all these patients are eventually going to relapse after the primary therapy, but there are clearly patients, a significant number of patients who after a transplant particularly, you see the monoclonal protein very slowly creeping up, this biochemical progression. And there's always, I think there's still an open debate in the myeloma community as to what is the right time to start therapy. But I think it's important to, akin to what we're talking about in smoldering myeloma, for example. But I think it is something to keep in mind. The kinetics of the progression needs to be taken into account when we are talking about the starting therapy. And hopefully there will be prospective trials examining that question as to what is the right time to start therapy. Now, we also want to take into account a few important points that we didn't know when the patient originally was diagnosed with myeloma. One of them is the functional high-risk patient population. Now, we all have, high-risk characteristics that we can identify at the time of diagnosis that helps us prognosticate, but there are patients who may look like standard risk. You give them the primary therapy, year and a half later, they are back in your office with relapse. And those patients are high risk. It doesn't matter whether they have a genetic marker or not that tells them it's high risk. So that is something that you need to take into account when you decide on the next line of therapy. And in addition, you also want to think about the aggressiveness of the relapse, not only just in terms of the doubling time of the monoclonal protein, but also are they presenting back with end-organ damage like hypercalcemia, renal failure, and so forth. Now, a lot of patients tend to be, especially if they present with more aggressive relapse, their performance status may be poor. They could have some residual toxicity from the previous therapy they had, for example, neuropathy or cardiotoxicity that they may have developed, and that needs to be factored into what regimen you're going to use for these patients. And then, of course, for the older patients, we want to also take into account some of the logistics of getting these therapies to the patients. So, so basically, disease-related factors as well as patient factors need to be considered. Now, when you talk about the decision, what the particular regimen you're going to be using in that early relapse, you also want to think about the cross-resistance across the drug classes, right? So, obviously, if somebody is resistant to, let's say, lenalidomide, we know pomalidomide will work in those patients, but not the vice versa. And similarly, somebody who is resistant to bortezomib may have some benefit from carfilzomib, but the reverse is probably not necessarily always true. But either way, I think the PI resistance to one certainly increases the chance the other drugs in the same class will not work. But more importantly, I think, what are the different regimens we have? As Nina already said, obviously we have a boom in terms of all these new therapies out there, and that also gives us the options to give patients treatments or treatment classes that these patients have never seen before. So one of the things that the guiding principle that we often use is you want to treat the patient with at least a 2-drug plus steroid combination. So the triplets is the way to go. And we have seen that from multiple phase 3 trials, not only in terms of PFS, but also overall survival. And it's not just any triplet. We want to try and give them a triplet that contains drugs or preferably even drug classes that they have not seen before. Now, this is an easy thing to do when you're talking about the second or the third relapse because we have so many different drugs. So we have the PI plus IMiD combinations, which could, in somebody who has seen VRD before, we can certainly use either carfilzomib or we can use pomalidomide-based combinations. If they haven't seen monoclonal antibodies before, we have good data with combining the anti-CD38 with a proteasome inhibitor like carfilzomib and also second-generation IMiD like pomalidomide. And then we have also other monoclonal antibodies like ilotuzumab. So I think the second and the third relapse, it's easier to pick a regimen where you still are able to deliver therapies that are non-cross resistant. But of course, it becomes a challenge then you go through the third, fourth, and fifth relapses. And of course, we'll hear about that, the new modalities from both Sagar and Nina after this. So what is the data that is, that kind of drives the selection of the regimen in someone who is relapsing after their initial therapy? So at least in the US practice, think about that patient in your practice who has the first relapse, right? The majority of them are going to be on lenalidomide, because they were on len maintenance after transplant, or they got a VRD therapy or DRD regimen and they continued on the len maintenance after that. Now, there are obviously trials. So the antibody-based combinations, we have trials that have looked at the carfilzomib combinations as well as the pomalidomide combinations. So here we have the Cante trial that looked at Daratumumab in combination with carfilzomib dex. The data looks pretty good in terms of combining the anti-CD38 with carfilzomib. The triplet did very well. Similarly, with Daratumumab with pomalidomide and dexamethasone, we have the Apollo trial that again showed that adding the CD38 in that first relapse, and again, these are patients who did not see that as part of their initial therapy, it clearly makes an impact in their outcomes. And now we also have the data with the isatuximab, very comparable to the Daratumumab in terms of their efficacy from an anti-CD38 strategy. You can see that both the Icaria trial that looked at isatuximab in combination with PomDex, quite comparable to what we saw in the Apollo trial with the Daratumumab. And when you look at the Bcma trial, again, we see a significant improvement in the PFS, and some updated data shows really nice PFS with the isatuximab, carfilzomib dex combination. And this is again updates from these same trials. With the Apollo trial, you can see that with a median of almost 2.5 years follow-up, the median PFS for the Daratumumab dex was about 9.9 months, and you can also, and the responses did deepen. And when you look at the data from the the 014 trial, this is again a slightly different patient population, but with the Daratumumab dex, again you can see a significantly, really nice PFS with this regimen in terms of the second line and later therapies. Now, there is obviously longer follow-up from the ICARIA data as well, which have just looked at isatuximab and POMDEX. The median overall survival with isatuximab was about 25 months compared to about 18 months with the control group. So significantly better PFS overall survival with both isatuximab and daratumumab in combination with pomalidomide with longer follow-up from these phase 3 trials. Now, there are obviously, there's also going to be, there's been updates with Bcma, which shows a nice PFS there of almost 42 months with the isatuximab carfilzomib combination. Now, there are other newer mechanism of action drugs. So, for example, selinexor has been combined with bortezomib in the Boston trial. So, the SVD compared to bortezomib dex. And it's important to note that in the SVD arm, it was again a weekly bortezomib compared to the twice weekly in the control arm. And even with that, you can see that there's a significantly improved PFS with the addition of selinexor to the bortezomib dex backbone. And again, opens up, again, you can't compare these different phase 3 trials in terms of the absolute PFS, but certainly demonstrates activity for this oral drug, which, since there have been other combinations that have been studied, including combinations with daratumumab, pomalidomide, as well as carfilzomib and selinexor. So, again, when you look at the subgroups within the Boston trial, you can see that patients did benefit irrespective of whether they had been treated with a proteasome inhibitor before or whether they were proteasome inhibitor naive. Of course, if they were naive, they did much better. But again, activity in both these patient populations. Clearly, the safety is something that we need to take into account when you use drugs like selinexor. It does cause significant thrombocytopenia as well as significant GI toxicity. Certainly, it appeared maybe not as obvious in the phase 3 trial, and especially with the once-weekly regimen, it seems to be a lot better tolerable than what we initially saw with the twice-weekly regimen. So obviously, we have these multiple different drugs that have been approved, and you'll hear more about the approved drugs, including the anti-Bcma strategy next, both in terms of antibodies like belantamab as well as Carte and the newer platforms like the bispecifics. So thankfully, we have all these different drugs that we can use one after the other in variety of different combinations to continue to control the disease for longer periods of time. Obviously, we saw, the data with median overall survival exceeding 10 years, and that's obviously a significant part of that was the upfront therapy, but it's also because we have all these other therapies that have come since then that allows these patients' disease to be controlled on a long-term basis. So maybe I'll hand it back to Nina here for the discussions regarding this section then.
Yeah, I mean, what you really pointed out is that we have so many options in this 1 to 3 prior line space. And yet, we also have this confusion because we're changing things up. So if you had the case here, this RVD, transplant, maintenance, how do you figure out what you do for the next step? Do you do CD38 in combination with POM-based or carfilzomib-based? What do you do, Shahji?
So I think the easiest thing is the fact that an anti-CD38 strategy should be there in that first relapse based on everything we have seen. So the question is going to be, what do you combine that with? My preference in somebody who is truly refractory to lenalidomide has been using carfilzomib if they can tolerate the DKD or a isatuximab carfilzomib dex regimen. And if they have been off lenalidomide for a while before the relapse, then it's a toss-up. So, but I prefer to use the POM in that setting because it's a little bit more convenient for those patients, especially when you're thinking about subcutaneous data.
Yeah, it definitely is convenient for them to have that option. What about you, Sagar?
So, our approach in this context has been to go to POMDARA as first relapse. And at ASH this year, Nisha Joseph looked at that data from our center and showed that if you were 3 years or more from diagnosis, the benefit for Pomdera was actually quite good. If you were less than 3 years from diagnosis and you relapsed, those patients seem to have really short PFSs, and that's where we go to the PI plus Dara in that situation. But I agree that you want a CD38. That's the backbone. And
Right.
the question is, what are you going to add to it?
Right, and I think that even today we saw some phase 2 data, the Dara KPD from Andrew Yee, and that had a 95% overall response rate. It's hard to know what these things do after, you need the longer term data, but people may even want to consider quad therapy in these patients depending on how aggressive their relapse is.
It's the wave of quadruplets in the first relapse.
That's exactly, if not up there. So if we think about this case again, you can see the same case. Now we're going to kind of evolve the case a little bit. Treated with RVD transplant, got rev maintenance, now had progression after 3 years and had mild renal insufficiency. This patient actually got Dara-Pom-Dex, achieved a VGPR, but this only lasted about 1.5 years. So as Sagar was saying, this is kind of that 3-year mark where the patient could have gone either way. So only had 1.5 years benefit from the Dara-Pom-Dex. And so we think, what is next for this patient? Now we've talked about some of the drugs that we haven't used. What would you think about using as far as a carfilzomib-based regimen for this particular patient? What do you think, Sagar?
Yeah, I mean, I think that's where we would go, and whether it's Cardex at 56 twice a week or whether it's Carcyclodex, those would be things that we think about in that situation.
And what about the SVD regimen? Would you use this in this particular patient population? Or particular patient, I should say. Shaji?
I think I would agree with Sagar. My preference is, again, just like we talked about Dara being, or the CD38 being important in that first relapse, I think the carfilzomib should be the backbone here. The question is, you can certainly combine selinexor also with carfilzomib. That's not an unreasonable strategy given the phase 2 data.
Yeah.
But certainly the carfilzomib, and then you have the options of what you add to that.
Yeah, I mean, if I was thinking about FDA approval, SVD is an option, and it's good that we have this data about the prior bortezomib exposure not affecting this too badly, because of course this person is not actually refractory to bortezomib, right? They have not progressed on bortezomib; they just finished their bortezomib in induction, so that's an option. But I agree with you. I probably would have gone with carfilzomib, and if we're thinking about things off-label, I think the SKD is definitely a good option for these types of patients. And if you're thinking about these options, are you already thinking about using a BCMA therapy? Is that playing into your mind about what you're going to do? Yeah.
Absolutely.
Yeah, I
think
agree.
It's right now with the availability of the BCMA targeted therapies, we are really looking to see if we can use one of those different platforms targeting BCMA at that time of the relapse, especially somebody who is already seen the anti-CD38, have seen the carfilzomib, have seen obviously the IMiDs.
Yeah. So go back to your iPad and you'll see that there's another question that you can answer as a follow-up on sequential therapy in relapse refractory myeloma and evidence supporting novel triplet platforms in early relapse. So just take a second to answer that question. All right, so I'll move on to the next. Okay, now we're going to get to the fourth patient. This is Samantha, and this is about turning into BCMA for pretreated myeloma. So Samantha was diagnosed at 62 years old, RIS as stage 1, standard risk, got RVD induction, transplant, Len maintenance, actually did get a CR. That lasted for about 3.5 years, but then had progression, and she also got DPD, achieved a VGPR, but at the 1-year mark had new symptomatic progression with a new L2 plasmacytoma, also had rising M protein. She was treated with some radiation, but then also got carfilzomib, cyclophosphamide, dexamethasone. Now, this only lasted 8 months. Of course, we see this pattern, right? The more treatments you go through, the less time these last. And after 8 months of Carci-Dex, she had progression. She did go on to selinexor, bortezomib, Dex. It really didn't respond very much, had stable disease at most, and then had progression. But she's actually doing fairly well. Besides this L2 business and a little bit of neuropathy, she's actually doing pretty well. So what factors in Samantha's presentation can help inform these treatments decisions about what to do next? So looking at the NCCN guidelines for late relapses, so there's at least 3 prior lines of therapy, you do have the option for a BCMA-directed therapy. So you have Carte therapy now approved, as well as belantamab, mafodotin. These are among the recommended strategies for the more heavily pretreated patients. There's some slight differences in the indications. Belantamab, mafodotin is after 4 treatments, which include an anti-CD38 monoclonal antibody, PI, and IMiD, whereas the idacaptogene viclucel and ciltacabtagene autoleucel, which are ide-cel and cilta-cel respectively, BCMA CAR T therapies are after 4 prior lines. So there's a little bit of subtle differences about how you get there. It's important because your patients have to, of course, get insurance clearance if they're going to do that. So you want to make sure you set them up nicely. And after at least 4 prior lines of therapy, if you've had triple or penta-refractory disease, then selinexor or dexamethasone is approved in this situation. Although, as we talked about, the weekly dosing of selinexor can be a little bit better tolerated. And this particular regimen of Selidex is twice weekly dosing, which has some different side effect profiles. So these are your options in this late line relapse. And for all that we talked about how we're doing so great in myeloma, kind of like, okay, there's an unmet need here, right? There are actually not as many options as you'd want. Now, what is the rationale for targeting BCMA? BCMA stands for B-cell maturation antigen, and I really like this antigen as a target for these very effective T-cell and antibody drug conjugate therapies because it's really expressed on these late-stage B cells and into plasma cells, almost uniformly expressed on plasma cells, and actually not expressed on very many other types of cells, which makes it a very good target for effective therapy because you want to have a lot of on-target effect and have very little off-target effect. So this is one of the things that's been a nice find for us, and I actually really encourage anybody who's in target discovery to keep doing this. We need more BCMA-type targets, and we found a few, but these are really important for these effective strategies that we have. I want to talk a little bit about ide-cel, which is a BCMA-directed CAR T-cell therapy for relapsed refractory multiple myeloma. Now, this was sort of the first FDA-approved BCMA-directed CAR T therapy, and this was based on this development of program that the investigators were able to show initially in their phase 1 trial, which is probably about 5 years now. They had this overall response rate of almost 90%, and this led to this phase 2 KarMMa trial, which looks at the the efficacy and safety of ide-cel in triple-class exposed relapsed refractory myeloma. As you can see on the right-hand side, the design of a CAR T-cell therapy really combines the best of both worlds with specificity on the extracellular domain of an antibody to an antigen, but on the intracellular domain has the functionality of a cytotoxic T-cell with the co-stimulatory domains that include the 4-1BB as well as the primary CD3 zeta chain. So this allows the T-cell to be very active when it's engaged specifically with the BCMA antigen in this case. So the KarMMa phase 2 data, the pivotal KarMMa study, showed the overall response rate in all dose groups to be 73%, which was on the right-hand side, as you can see. But there were actually several dose cohorts that were explored because we weren't really sure at the time what was going to be the best. And so you have people in the 150, 300, and 450. And you can see here that there was a dose-dependent effect. And the patients who received the 450 million dose, this is a flat dose of CAR T-cell therapy, had an overall response rate of 81%, which is higher than the general group of 73%. Now, these responses tend to be pretty quick, and you can really see them within 1 month. There have been several posters last ASH and now even at ASCO here showing that what you're doing in that first month with MRD status and how your bone marrow looks actually can be very predictive of how the patient's going to do. And these patients got to CR at a median of 2.8 months, probably because it takes time to clear that myeloma protein to get to that IMWG response. And you can see that we had a good follow-up there, a little over a year across the dose levels, and you can see the depths of responses on the graph there. Now, we know that the progression-free survival for all of the patients is somewhere in a little over 8 months, but if you look at 8.8 months, but if you look at the dose levels of the 450, which is that third line, but the top blue line on the left, the PFS there is about a year. So that's the going forward sort of recommended dose that this cell therapy is approved at. And so it's about, you can tell your patients about a year. That's 50% of patients do better, 50% do worse in that dosing category. Now, what about overall survival? This was updated a year ago at ASCO by Dr. Anderson, and you can see there that the median overall survival, the median overall survival is about 2 years, and this does not change whether it's 3 lines of prior therapy or 4 or more prior lines. And the reason that's important to know is because the clinical trial eligibility in KarMMa was at least 3 lines. However, the FDA label is at least 4 prior lines. So we wanted to make sure that patients were actually going to get the same benefit whether they had 3 or 4 lines. And I'll admit, when this was first approved in 4 lines, I thought, oh, that's not going to be so easy. But now we're doing all these things up front. It's actually kind of hard to get them to the fourth line without thinking about how this could affect the collection. And when you look at the real-world data, this is actually just hot off the press presented. You can see that the patients that did not meet KarMMa criteria in the no were able to get some standard of care T cells, and you can see that there's more patients being pentarefractory and less fit, but actually the safety is actually pretty comparable. And if you look at the efficacy, patients are still able to benefit from getting ide-cel therapy. And so I think it's important that we don't just think about the patients who would have met clinical trial eligibility, and we can talk about what that means, because that's a variety of different things that the patients had to be. Certainly we have a little bit more flexibility in the patient's eligibility for CAR T-cell therapy now that they're going to be getting therapy standard of care. Overall survival really didn't differ very much in these two cohorts of either meeting or not meeting KarMMa-1 eligibility criteria. Now, there is another CAR T-cell therapy that targets BCMA that has also been recently FDA approved, and this is cilta-cel, and this is based on the Carte data. I want to take a moment to point out a little bit of difference in cilta-cel versus ide-cel. The extracellular domain of this CAR T-cell product binds to two different epitopes on the BCMA protein, so it's a little bit different. It may explain some differences in kinetics or may not explain any differences. We don't know, but we know that it's a different product from the KarMMa product. So cilta-cel was evaluated in the CARTITUDE-1 study, and this was testing patients who had at least 3 prior therapies, including PI, IMiD, and anti-CD38 antibody therapy. Very similar patient inclusion criteria to the KarMMa-1 study. As you can see here, the initial efficacy that was read out showed an overall response rate of 98%, which is very impressive, and more so that the depth of response also very impressive at least 95% of patients getting at least a VGPR or better. So that's a 90% reduction in their myeloma markers. Now, we again had hot off the press from this year, 2-year post-last patient results. This was presented this morning at ASCO, and the overall response rate, of course, remains 98% because these responses occur quickly. And actually, 83% of patients did achieve a stringent CR with longer follow-up. We actually were not able to yet get the median PFS. I was hoping we were going to find it at this poster, but it was not there. And in fact, it turns out about 55% of patients at the 27-month mark, a little over 27 months, are still doing well, which means, we're heading into that 27, 28-month mark that we might see this PFS. We don't have the updated data yet, but very nicely, there's still being, this cilta-cel product is being explored in multiple CARTITUDE platforms, which look at both earlier relapses, different aspects of lenalidomide refractoriness, as well as looking at this as instead of transplant as well. CARTITUDE-1 has some nice PFS data. I think what you can see here, the PFS rate at that top there is best for the patients who get into a really good response. Similarly, for people who get MRD negativity, those patients also do very well. I'm really looking forward to seeing how much survival we can sort of squeeze out of this product. And the reason is that it's a one-time treatment, similar to ide-cel. And we've already talked about how patients get therapy after therapy and have to get cycles and cycles of therapy. This is just one therapy. And so it's going to be really interesting for us to know whether we can give this therapy and have a long PFS or long overall survival for patients with such heavily pretreated disease, and maybe even better potentially if we use this as an earlier treatment modality. So looking at BCMA for pretreated myeloma, we talk about our patient who had 4 lines, right? RVD, transplant, and maintenance, that's 1 line, DPD 2nd line, KCD 3rd line, and then had SVD 4 lines. So this patient did have 4 lines of therapy, had exposure to all of our classic drugs. So this patient, I think, and the patient has pretty good performance status, would be a very clear candidate for CAR T-cell therapy. So I think one thing that we want to talk about is referral to a specialized care area that can give you, not all hospitals can give CAR T-cell therapy. You have to go to a hospital that can. And I really advocate for patients to be referred as early as possible. Of course, I love to see patients in the front line for transplant eligibility, but let's say that didn't happen and they got treatment somewhere else and they've had a progression. Even that first progression, those patients should be evaluated, I would say, at a specialty center. First of all, there might be a clinical trial of CAR T. That might be there. But secondly, you want to keep them in the mix because you want to know what they're getting next. There are some factors that might be associated with CAR T-cell therapy efficacy, and you want to keep that in mind when choosing possible therapies. What do you guys think about how early a patient should be referred to a cell therapy specialty center? Shaji?
I think I completely agree. I think looking at some of the clinical trial options would certainly be something to be considered early on. but the majority of the patients are getting treatment in the community, and sometimes it becomes, you have to factor in the patient convenience going to a referral center. But certainly, I think it's a discussion you need to have probably at the time of that third relapse, at least second to third relapse. So.
Yeah. What about you, Sagar?
Yeah, no, I think the same point. I do think there's value in having touch points with a big myeloma center, early relapse, mid, late, to sort of make sure that we've got the best optimal salvage therapies for them available. But before or as they're starting third-line therapy is a good time to check in with the cell therapy center.
Yeah, and I'm really getting changing my practice that we get to the third line and I start getting them evaluated in a way for Carte, because I know as soon as they progress to go to fourth line, you don't have to have these patients actively progressing to get Carte therapy. That's actually not in the label. So they could be on fourth line therapy, get their disease controlled, and that might correlate with better response, and then get to the next therapy, which would be Carte, if there's a slot, which is also a challenge sometimes for us. So want to think about different general principles of Carte therapy. So for ide-cel, the recommended dose is somewhere between 300 and 460. We really try to get to that 450 dose. As we were talking about, we really want to get patients referred to a certified healthcare facility that is able to give this cell therapy. That's true also for cilta-cel. And there, the dose range is 0.5 to 1 times 10 to the 6 T cells per single dose infusion. And in this situation, they also have to be referred to a specialty center. We think about for ide-cel not using the leukodepleting filter. That's true for most cell therapy products. You want to make sure that they're going to be able to get their cells. They're not going to be filtered out. Most cell therapy products also require pre-medication. We usually use something like Benadryl or antihistamine and Tylenol. We really try to avoid the steroids. And then we also think about how do we manage these patients sort of peri-Carte. So we talked about already that in both of these situations, they would have to go to a certified center. And how much of this can we do outpatient versus inpatient? All of these Carte cell therapies do cause CRS, or cytokine release syndrome, and that happens between 84% for ide-cel and almost 100%, 98% for, or 95% for cilta-cel. So you know these patients are probably going to get CRS. The timing is not necessarily clear. Seems to happen a little bit earlier with ide-cel versus cilta-cel, but they have to be monitored, and depending on what kind of structure the hospital has, they may be able to be partly outpatient, but partly inpatient with a quick pathway to get admitted. All of these have a REMS program. You have to make sure that you've registered and you've done training, that the staff has done training. You have to look for later toxicities, which may include things like neurotoxicity, which tends to happen generally a little bit after CRS, and something we've called a macrophage activation-like syndrome, MAS-like syndrome, where there's clearly an inflammation or inflammatory pattern in the bone marrow, causes some cytopenias, elevated ferritin, and these patients may be at risk for prolonged cytopenias, which may be a side effect of getting this very effective therapy. So again, have to talk with your community provider not only to get the patient referred, but also to manage the patient afterwards. Also some IVIG, et cetera, prophylactic antimicrobials. All of these are things that to be considered for a patient who is going to consider going to Carte therapy and has undergone Carte therapy. Thinking about CRS and Icanns with Bcma Carte constructs, as I pointed out, CRS happens almost uniformly for cilta-cel, 95%, ide-cel, 84%. Pretty much, they're variable, and I think there's some differences in kinetics between these two products. Median time to onset for cilta-cel, 7 days, and 1 day for ide-cel. Icanns was 17% for cilta-cel, 18% for ide-cel, but there were some sort of off-target toxicities, neurotoxicities in cilta-cel seen in about 12% of patients, and so that has to be looked after as well. These can be late onset as well. Infections are there. Of course, when it's fever and cytokine release syndrome, it's hard to know what the difference is, but there's significant immunocompromise that needs to be managed both from a preventative aspect and an aggressive early management. And again, cytopenias, delayed neurotoxicity, this can happen. And we have seen the delayed neurotoxicity in the cilta-cel program, and microscopically, I would say, in the ide-cel, but this is definitely a signal that we saw in the CARTITUDE-1 platform. So there's sort of 3 tenets for CAR T-cell therapy and patient referral. So most patients with relapse refractory myeloma can be considered potential candidates for CAR T therapy. I would say maybe sort of the no-goes sometimes might be dialysis because of the fludarabine, and we're still working on that as a myeloma community to get more access for these patients. The toxicity is different from transplant. I don't even like to compare the two because they're just different ways of treating myeloma, right? One is an alkylating agent, which is transplant, and one is an immunotherapy. So, of course, there's going to be different toxicities. They just both have the word cell in them. So, but other than that, they're very different. And I really think, as we talked about, early referral to a cellular therapy center is critical because a lot of logistics, and you have to train the patient again. Like, okay, I'm going to have a similar time scale. I got to come to the center, get collected, go home, maybe get bridging, come back. You just have to, it's hard for patients to know this in one day. So it's good if they can have multiple conversations with you. Another question here on your iPad that you can see as we move on. Try to take a moment to answer about choosing therapy for a patient with heavily pretreated treatment refractory multiple myeloma. Okay. All right, we're doing great. All right, we're going to go to the fourth case, last case. So what if Samantha had presented with a challenging comorbidity? Maybe she has underlying coronary artery disease, limited mobility, logistics are a problem, and she's not eligible to go to a CAR T-cell therapy. How would we have options that would be different for this patient? And I'm going to turn it over to Sagar to talk about this particular option.
Yeah, thanks, Nina. I think this is a little bit more challenging situation, whether the changes in comorbidity occurred as a consequence of all those years of treatment that were given before, or whether they were underlying at the outset. Clearly, this is somebody who probably should give you at least a little pause in terms of moving forward with a CAR T-cell, and certainly not having access to specialized care. As we talk about healthcare disparities and access in general, this certainly is a big issue for a number of areas in the country, particularly rural areas where driving 3, 4, 5 hours to get to a center is a bit of a hardship on a family. So I think we do need to know how one might approach a situation like this were such a patient available. And if you look again at NCCN guidelines for late relapses, what you'll see as available in terms of BCMA, obviously, as you just heard, ide-cel and cilta-cel are potential candidates or options for that patient, but belamaf probably fits the profile of this patient a little bit better, and being off the shelf certainly is a reasonable thing to consider as well. Now, there is also another option in selinexor dexamethasone. If I remember correctly from the case, this patient actually got SVD, and so has already seen selinexor, but certainly in my mind, the two non-cell therapy approaches that certainly have FDA labels in this situation are selinexor dex and belantamab mafodotin. So when we begin to think about belamaf or belantamab mafodotin, it is an antibody drug conjugate, which is a primary mechanism of action, but it also does engage immune activation through ADC and ADCC and other things along those lines. And I think that that's really important because what it speaks to is what are the optimal partners for belamaf when you think about combination therapy. And in this context, those can often include, for instance, IMiDs, which we know, even if the IMiD is not effective at killing the myeloma cell, the IMiD may be effective at activating immune system, activating T cells and NK cells, which may then be able to kill the cell through ADCC or ADCP. And then there is, of course, immunogenic cell death, which may be a partner effect as well. So these are all potential advantages of an immune-based therapy like belantamab mafodotin. And when you think about data and how to treat a patient with refractory 4 prior lines of therapy myeloma, sometimes less, maybe more, in the sense of this is actually a drug that's given every 3 weeks. They don't have to come into the office a lot in those 3 weeks. So from a patient-friendly perspective, this certainly does represent a very reasonable option as well. Now, this got FDA approval through the DREAM-2 study, which was a randomized phase 2 study comparing 2 different doses of belamaf, either 2.5 mg per kg or 3.4. And it is important, as we discussed in the poster discussion session earlier today, the 3.4 actually was the MTD from the phase 1. The 2.5 is the dose in the phase 2 that actually fell out as the better, more safe dose to give. But the MTD was, in fact, the 3.4 dose that we don't use any longer. And what you saw was about a 30% response rate. You did see VGPRs and even CRs in some patients here, which speaks to the novel mechanism of action. And more importantly, what you did see was a long duration of response. And so when you think about what this means in the larger context, Daratumumab was approved as a single agent in refractory myeloma with a 30% response rate and a DOR between 9 and 11 months. Carfilzomib was approved with a 30% response rate and a DOR between 8 and 10 months. So this is certainly in that same ballpark, and because it's a novel mechanism, I think really does have legs, if you will, in the context of 4 prior lines of therapy and triple-class refractory myeloma as well. Now, one of the things that I think was really important as we begin to think about combination therapy with belamaf is combining again with IMiDs. And the Algonquin study was probably the largest study that's been done to date, combining belamaf with pomalidomide and dexamethasone. And one of the things that I think is really important is you're seeing high overall response rates even in triple-class refractory patients. So IMiD, PI, and DARA refractory patients, 100% overall response rate, 72% VGPR or better. And I think that this is really important. The other highlight of this is really looking at alternative dosing schedules. And when you look at the DREAM2 study, if you take all patients who got belamaf at 2.5 milligrams per kilogram, what you'll notice is about 70% of patients had some form of keratopathy. Only about 18% had changes in visual acuity of 2 lines or more on the Snellen eye chart. So most patients may have had dry eyes or some mild changes, but some patients did have inability to read, inability to drive that was reversible in almost all of those patients. And this is sort of an onion plot, if you will, of the keratopathy that can occur, again, with or without symptoms. And what you see here is that the BCVA change of 20/50 or more, which is 2 lines on the Snellen eye chart here. You can see it's the sort of Duke blue, I guess, maybe the second circle down here at the bottom. That occurred in about 18% of patients. If you look at all patients, it was 72%, but a majority didn't have major symptoms, or dry eyes was the major symptom that they saw. Now, the take-home messages in terms of belamaf for the management team are that you need to reassure the patients that if you need to hold the dose, it's okay. In fact, in the DREAM2 study, most patients that had dose holds of even 12 weeks or more actually maintained or deepened their response. Only 15% of patients actually had progression during that dose hold. So it's okay to hold therapy to allow keratopathy to resolve. The second thing I think that's important is that you may find that a patient is responding, but every 3 weeks isn't the right frequency for that patient. And so it's okay to say, every time I give 2 doses in a row, I end up having to hold the 3rd dose. So maybe I need to dose that patient every 6 weeks. Maybe I need to dose that patient every 4 weeks. Maybe I need to think about dosing every 8 weeks. Those are all things that are being looked at in combination trials, and really maybe things that you learn from patient to patient that helps you manage that patient in a way that gets efficacy of the drug, but at the same time reduces dose holds or modifications because of developing grade 3 keratopathy. I'll turn it back over to you.
Great. Thank you. So I just want to take a minute to answer 2 follow-up questions on therapy selection and treatment refractory myeloma and managing BCMA-related toxicity. I'll give you a few more seconds to do that. Okay. This is perfect. We have about 10 minutes to wrap up. I want to talk a little bit about bispecifics therapy, and I think, Sagar, you're talking about this one, right? Okay, great.
Yep. So the other area that I think is really emerging rapidly, and there certainly are data sets that are being presented at the meeting tomorrow and potentially Monday as well, are looking at additional off-the-shelf approaches to targeting BCMA. And these really involve the bispecifics. And I'm sure you've heard all of us talk about the later patients are in their treatment, the less healthy their T cells are. But the bispecific data really almost speaks in the face of that not necessarily being accurate. Because what we're seeing with the bispecifics, whether it's teclistamab or elranatamab, or there are 3 other bispecifics in development in myeloma, all targeting BCMA, they all have response rates of over 60%. in the context of unhealthy T cells. And so I think we really need to understand what are the optimal ways to use this. As you can see, their main mechanism of action is bringing a T cell right next to a myeloma cell. And interestingly enough, there is emerging data suggesting that while myeloma is a blood cancer, it may behave a little bit like a solid tumor in that excluding T cell immunity from the core mass of tumor cells may be a reason why they escape immunologic surveillance or control, and that bispecifics may be a way to break that by bringing T cells right next to myeloma cells, allowing them to potentially be targeted and ultimately killed. So this is really an exciting era, and we're going to see a lot more incorporation of bispecifics in earlier relapse, and I think even trials are bringing it into the induction therapy setting right now. And again, there are abstracts that are being presented. My colleague, Dr. Nuka, is presenting abstract number 8007 tomorrow on Majestic 1, which is teclistamab, showing an MRD negativity rate of about 25% and about 17% at 10 to the minus 6. Remember, this is like 5 prior lines of therapy. So we're talking about MRD negativity in 5 prior lines of therapy. And so I think that's an exciting abstract. And then Dr. Jakubowiak is going to present an abstract using elranatamab, which is the Magnetism MM1 study. And this is looking specifically at patients who are exposed or resistant to BCMA-directed therapies already. And so this is, again, another important subset when we talk about sequencing BCMA-directed therapies, how this may work overall. So I'll turn it back to you.
Great. Just want to give a little shout out again to the Health Tree Cure Hub, which is a patient data portal. It facilitates patient data contributions and surveys and studies, and like I was saying, it really helps us to understand and helps patients to understand more what's going on with our diseases. We're learning from patients in this very comprehensive data set with over 10,000 participating patients. It's a lot of data, and these data sets are validated and have things like labs, genetics, prior treatment, PROs, and demographics. So I think getting more information in there helps us to learn more about patients and get more information out there. So these are really new developments in myeloma care, and these can create opportunities to share data directly from patients. And it's really been nice to see this evolve, and a lot of patients have been involved in this effort and have really benefited from this platform. So we have actually a good little section of time, some 5 minutes for symposium summary and audience Q&A. I'm going to, we can do mic passing, but I'm going to start with one question that came in through the iPad, which is talking about high-risk patient in the sense of having 3 copies of 1Q. So this would be considered 1Q gain, not 1Q amp, which are 2 different things. And I actually struggle with this too. So I want to know, what are you doing for 1Q gain?
So I consider them as high risk as well, and I think we have data that we have looked at from the Mayo data set that was published. The 1Q is, and recently the JCO came out the second revision of the RASS, which also demonstrates the prognostic value for the 1Q gain. I think both are prognostic. Certainly 1Q amplification, since we have a more poorer outcome compared to 1Q gain, again depending upon which set you're looking at. But certainly, both of those patients, I would treat them as high risk at this point in time.
So you would do Dara RVD, then VD,
ERD,
maintenance. Okay, Sagar, what do you do for the 1Q gain or amp?
Yeah, the 1 extra copy is, I think it is hard to know what to do. It's clearly bad, 1 extra copy, when there's other cytogenetic abnormalities. Yeah. So that one to me is a no-brainer. When it's just 1 extra copy without anything else, at least in the RVD 1000 data, it's not quite as good, but it's not statistically different. And since 50%, almost 50% of patients have some changes in chromosome 1, I'm a little hesitant to make changes in maintenance therapy, but I think it's a controversial area.
And I think it's interesting to note that the Forte data did well in high-risk patients to get this KRD, transplant KRD, except in the 1Q amp patients. So
it doesn't make sense.
You would think, okay, we'll give carfilzomib, which is my go-to for high risk, but that's one of the patient data sets that doesn't support that for 1Q.
Right, but I think it's very important because the endurance trial showed exactly the same thing, that the 1Q amp did not benefit. The 1Q gains did to some extent. So I think 1Q amp may reflect biology that's more than just the extra copy.
Yeah.
So that's something to keep.
So maybe KRD could be something we would give.
At least the 1Q gain certainly could be considered.
Yeah.
Great. Any questions in the audience live? Don't be shy. Okay. So what are you most excited about in the future treatment of myeloma? Give me like a 5-word answer.
So I think the most exciting thing is getting the immunotherapy to the first part of the first-line therapy. I think is going to be the biggest change in the next 5 years.
All right. Sagar, you agree?
Yeah, I think incorporating both cell therapy and the antibodies, whether they're bispecifics or specific targets, figuring out how to put them all together in a treatment plan that gets deep responses, but then lets us stop treatment.
Yeah.
I think the continuous therapy mantra has gotten us where we are. We need to challenge ourselves to do better.
I agree. I think having seen patients go 3 years after Carte therapy reminded me that people actually have a life outside of myeloma. And if there's something we can do with bispecifics and our novel therapies to make DEX-free, upfront therapies or second-line therapies, it'd be great. I really think that there are a subset of patients for bispecifics that should not get indefinite therapy. And that's the place I really want to do more research about stopping therapy, because I think the T cells do get exhausted. And so it'd be good if we could have maybe 8 cycles in your first line, and that's it. We'll see what happens. So I really encourage novel clinical trial designs for all of us to think about these things. Do you have a preference of Carte versus bispecific?
I think the Carte results are really outstanding, but the problem is the majority of our patients cannot access that at this point.
Right. So if access wasn't an issue.
Access is the issue.
Yeah.
I think in that setting, I see the bispecifics really filling in a gap once they get to be approved.
Okay. Sagar, you agree?
Yeah, I know you always say they're one and done, but they're one and done until they're not. And unfortunately, there's no plateau on that curve. And so it's not ALL and it's not diffuse large B-cell lymphoma. So I think putting the two of them together, giving a CARB and then following up with a bispecific if they're not in MRD negative CR, that's a way to sort of get longer progression, maintenance, if you will, and lets you deal with the fact that they don't have long persistence.
Yeah, actually, I just saw this poster from the Mayo. Really great data from you guys about MRD negativity and getting that within the first month. And you don't get there, those people should go on clinical trial. And I think that's really great data that you guys have. With that, any other questions in the live audience? Yes. We need to get.
There's a mic coming to you.
Yes. It's a quick 30-seconder.
So now in community setting, they are offering us that commercial availability of MRD testing. So if I have a myeloma patient, I do MRD. So how often I do it? MRD negative once is good enough? Or means like, can you expand on that? Means, or should I change treatment if I don't achieve MRD negativity?
Yeah, these are very important questions, and I think we struggle with not having a lot of data to support using it as a tool to change therapy. Right? I think it's a great prognostic factor, and I think when you we don't routinely do MRD testing necessarily in all the patients outside of clinical trials. I think clinical trials is where we're going to learn a lot from them. In our own setting, where we use the data mostly for the MRD data, the patients with high-risk disease, where we see that, again, without prospective data, but just based on the fact that the patients who have high-risk disease, who don't get MRD negative, have really poor outcome. Those patients we tend to often change therapy or try to deepen therapy, intensify therapy if they don't get to be MRD negative. What are the time points to do it? I think these are the time points where you might be already pre-planned change in therapy, right? You're going from post-transplant, you're starting maintenance. That may, in a high-risk patient, if you're MRD positive, that may be what may make you decide to give few cycles of consolidation and then go to maintenance. So I think points of pre-planned change in therapy would be the best place to do MRD testing right now in the standard of care scenario. So.
Great.
You wrote the paper, so I'm not going to disagree with you.
That's right. You're the expert. Great. So this has been a wonderful symposium. Thank you so much for being engaged. It's been a great discussion with Shahji and Sagar. And you can visit us at peerview.com/2022 myeloma, not 2020. And complete and submit your post-test and evaluation for credit. There's also slides that you can download as well as practice aids and watch the replay of this event in the next 24 hours. And that's going to be followed by online activity in the coming weeks. And we want to say thank you for joining us.